Yep, today we are finishing up the legal issues for management of care. Remember, hopefully by now you've heard that we have a 7 for $77 deal. And really quick, because I don't want to spend the video promoting, I hate that. But real quick, 7 for $77. Most of you already know we have something called pink packets. Well, there's a white one thrown in for this one. So here we go. The pink packets include basically everything you need to pass the NCLEX exam. It's kind of cool. So management of care, which is what we're doing today. And this has all kinds of things in it. It's got ethical, legal, delegation, SBAR, informatics, workplace conflict, therapeutic communication, and non-therapeutic communication. It has everything. The next one, because that was one, the famous Oh My God study guide, which tells you how to pass the test without spending money on a review, tells you what subjects to study, what score you need in those subjects. It also tells you the order of how to organize yourself with those subjects, which subjects are not as important. It tells you diets and nutritions, positions, pharmacology. This is huge, this is famous, this is very popular. People carry this around with them even after they're done with their NCLEX. So that's the Oh My God packet. That's number 2. The third issue is the number 1 area of failure. This is your reduction of risk. Please remember, people, that reduction of risk and basic care and comfort are the 2 areas of really common failures on the NCLEX. Together, the Oh My God and the reduction of risk really give you all the basic care and comfort that you need. So what is reduction of risk? Right there, procedures. That's what it is. It's procedures. That's all it really is. So reduction of risk is a high failure area. If you're watching this and you failed your test before and you got that candidate report, you need to know that candidate report matters. Stop burning it for firewood. Stop throwing it away. Make sure you look at where you failed. It matters. Now, I also give you a consultation if you need help talking about what you failed in and how to pass the next test, like $25 consultation. It is going up next year, so get it in while you fit it in. Long as you text me before next year, you still get the deal. Okay, so here we go. This one is huge. Infectious diseases, transmission-based, transmission-based precautions. If you got your 7 for 77 already and this wasn't in it, please hit me up. You need this. I think it's another packet that we give with it sometimes. So you just want to make sure you got this one. Again, it's pink and it has those transmission-based protocols and precautions. It also has a huge list of about 50 infectious diseases that you will need to make flashcards of. This is what you need to make your own. I'm not making them. You make your own flashcards. You put the disease on the front, the other name for the disease on the back, and the precautions that you need. What's a good example? Well, on the front, maybe you put measles. On the back, you put rubeola. On the back, you put airborne precautions. Now you got me, okay? Here is the, let's see, which one is this? This is the 5th one. It's newly revised for 2024, your medication category. So that's number 5. And then we have our psych meds, because psych is a major focus area of NCLEX, and 70% or more of the meds on NCLEX come from psych. The others come from cardio and GI. Okay, so that's number 6. And because psych is so important to you passing your NCLEX, and we're all going to get psych patients no matter what on any unit we work in, boom. Psych is the white packet that goes with all the pink packets and makes up the 7 for 77. Now, do not call me and ask me about my packets. You just gonna get the regular little link that gives you the regular cost. No, if you want the deal, you have to say, I want that 7 for 77. And I am done with this deal as of the 1st of January. So get it in where you fit it in, right? I mean, come on. Now, so speaking of psych, this is also a psychiatric issue. Restraints. Today's lecture is all about restraints in terms of the management of care. It is the legal issue of management of care. Remember, management of care is ethical, legal, delegation, prioritization, who you see first, workplace conflict, roommates, it's SBAR, it's nursing informatics, it's, if I didn't say it already, I think I did, it's delegation, it's therapeutic communication and non-therapeutic communication. It's a lot. So this video is the last legal video. The next one is ethics, okay? That's like fidelity and justice and beneficence and non-maleficence and autonomy and advocacy and all those funky foul words. You know what I mean, those $4 words, you remember. So let's get started, shall we? Let's go ahead and talk about restraints. Now my board is busy, it's crazy, and it's a way to help you take better notes. So I'm gonna try to go right in order of the board. First of all, when it comes to restraints, you've got some extremely common tips and concepts that are on HESI or NCLEX or any other test you're going to take. So come with me. When it comes to restraints, you always need an order. Don't go tying people up and then get busy and forget to get that order. No, you need to have a friend of yours or yourself get that order as soon as humanly possible. I remember a situation where the patient was in hospice and the hospice team came to see their patient. There was no order for the restraints, yet the patient was tied up. It did not go well for that nurse. In fact, she got a referral to the Board of Nursing because you're just outright breaking the law. And what did you just do? Well, you did what we call an intentional tort, false imprisonment. Now, if you don't know what a tort is, that's the video before this one. But that was an intentional tort, which kind? False imprisonment, when you tie people up without an order. Okay, now, of course, it's better to get the order ahead of time, but sometimes you can't. In terms of impending death, violence, suicide, you cannot get an order first, but you can get an order right away after that. Not only that, half the time, if any of that is going on, especially the violence component, we're calling a code violet anyway. So you're going to get some doctors at the bedside anyhow. All right, so be careful here. Remember that we are trying to use the least restrictive method of restraint, which is usually mitts. We call them oven mitts. Mitts are kind of nice because they are comfortable. They really just keep you from pulling your lines out because you can't get your fingers to work in a mitt. And so that is the least restrictive type of restraint. And you have to be careful because when it comes to restraints, there's several different kinds. One is a vest restraint, which is usually put on, and remember that I said this, it's strapped, it's put on the patient, and the straps have to go in front of the patient, crisscross, not in back. And that is to protect the people around the patient. So it's to protect others typically. The wrist restraints are for the protection of the patient typically, right? Now, we never use wrist restraints with children. What do we use instead? Elbow restraints. Don't forget I said that. All right, so we agree. We use the least restrictive. Remember also that anything that limits the mobility of the patient and they can't take it off is a restraint. So side rails up times 4 is a restraint. Now, believe me, side rails up times 4 is a very legitimate precaution if your patient's at risk for seizures. It's not considered a restraint, it's considered a precaution. But you better have those side rails up ×4 and padded bed low break on, right? Right. So if there's no seizures and you got 4 bed rails up, you restrained your patient. False imprisonment if there was no reason. Ooh, okay, so remember I said that. Now, when you put this patient in restraints, you create more work for all of us, nurses, doctors, everybody, because now we have to assess this patient every 15 minutes. Yeah, and since that's like nearly almost impossible, a lot of times the restraint patient might end up with the sitter on top of that. Because who can watch, who can like come on, let's be real. But legally, this patient requires every 15-minute eyes on the patient. Yes, some things can be delegated, but be careful, okay? I'm just saying, be careful. Follow your facility's guidelines. These restraints must be removed every 2 hours. And during that 2 hours, you are doing a list of things and you're documenting that you did that. Now, what are the things that you're doing every two hours when you remove the restraint? Maybe one arm at a time, maybe one leg at a time. You got to be careful. You got to be safe, but you're trying to remove these restraints every 2 hours. What are we doing? Neurovascular assessments. Y'all remember the 5 Ps? What are they really like 6 Ps now? You're assessing for pain, pallor, paresthesia, pulses. You're assessing for pressure. You know, you're really looking at those Ps. Remember the Ps? Pressure, pain, paresthesia, pulses, pallor, paralysis. You're making sure the patient can do this, right? That's your assessment for paralysis. You know, if they can do that, I mean, come on. So you're looking at the color of the limb. If the extremity is restrained, you're looking at that patient's color. Are there any color changes? You're making sure that the skin is intact. There's no ligature marks and all the stupid shit you might see. Okay, so you're doing that. Skin integrity. That's part of your neurovascular assessment as well. You're checking that range of motion. That goes back to the P for paralysis, range of motion, right? Okay. You're trying to offer fluids and toileting, nutrition. You're offering all that, see? So this is what is mandatory that you chart and do every 2 hours when a patient is in restraints. Now, you need to get this patient evaluated face-to-face by a provider. That's why it says face-to-face evaluation by a provider within 24 hours. And that order for the restraints can't be a PRN order. It must be renewed every 24 hours. And so a lot of facilities, they just automatically renew the restraint order in terms of the actual logistics of the EPIC system. The physician looks at everything and they have a nice little auto renew if the patient is in restraints and the documentation supports the need for continuing the restraints, which means every 8 hours or so, the nurse, the RN, has to make sure this is really needed, okay? Now, don't get it twisted. I already said this before. We talked about it. We also did a whole thing on antipsychotics and the fact that they are considered, for some people that don't have a psych problem, they're considered chemical restraints. This is your Seroquel, Abilify, Geodon, Haldol, all of them daggone antipsychotics. If the patient is not schizophrenic or bipolar and you're using these medications, you are essentially giving them a chemical restraint, which could be appropriate, but be careful because it may not be. And it is a focus area of so many organizations because we know that people are mistreating and abusing some elderly patients by just drugging them up. And it's ridiculous, okay? Another category of medications that might be considered a chemical restraint are your benzodiazepines, your Ativan, your Xanax, your Valium, all of those. Versed, of course, you know, like those could be considered your chemical restraints. Sleeping aids or sleeping pills, your Trazodone, your Ambien, all those. I'm giving you brand names, right? Better look that shit up. Uh-oh, here's a real popular one, especially with children. Benadryl. You done slept that patient with some Benadryl. That was a chemical restraint. I see you in jail. I put some money on your books, but you know what I'm saying. Okay, so this was like a quickie, right? So what else do we have to remember about these restraints? Well, here you go. Make sure you know, quote me, that you need quick release knots for restraints, okay? Something you can pull and release real quick release, slip knots or knots that we can put in. And you always attach the restraint itself to the bed frame, or if they're in a wheelchair, it has to be the chair frame, never the wheel, never the side rail. You know, people be doing crazy stuff on steroids, you know, okay? Now, one of these select alls that you're going to get more often than not on some of these standardized nursing exams, HESI, ATI, NCLEX, will include what did you do to try not to use restraints? Because not only are you supposed to use the least restrictive, you probably don't need to be using these restraints the way people be using them. I don't tie people up. I know you kind of kinky and you get off on it, but I really don't tie people up if I can help it. I mean, when I come on and the patient's tied up, I do a thorough assessment if I can and figure out, well, what the fuck did we tie this lady up for? Now, there's some things you should not be tying people up for. And let me make sure you know those because this is like very serious. Stop tying people up. Stop it. Because they won't stay in bed. Oh, yeah, you're going to jail. Yeah, you're going to jail and hell because you cannot tie people up to keep them from getting out of the bed. That's just crazy. Okay, so remember I said that. Stop tying people up because they're wandering. Cut that out. Because in your nursing program, you were supposed to use some of your nursing knowledge to know how to deal with patients who wander. Stop it. Oh, I seen this. You thought you was going to tie folks up just to punish them, huh? They getting on your nerves, talking shit, and you just, fuck it, we tying you up. No, it's not supposed to be a form of discipline. These are grown-ass people. Why is you disciplining them with tying them up? Come on now, Jesus. Here's one. Well, you know, Tom, Dick, and Harry and Sue, Jane, and Mary called off. So we ain't got but 2 nurses. Y'all gonna be tying folks up tonight because we can't have them getting out of bed and falling and whatnot. So go ahead and get ready. We should probably get a few restraints on room 3. It might be a good idea to throw 7 on in there. And number 9 is a fool. So just tie them up right now. Where they do that at? A lot of places. Stop it. Short staff is not a reason for you to be tying people up. Okay, now that we got that out of our system, let's talk about alternatives to tying people up. I would have to say 90% of the time when I get a report and I find out that one of my patients is in restraints, I said 90% of the time. 90% of the time, I can use alternatives and get them the hell out those restraints. We are not being very creative. We are not thinking outside the box. We are not using what we were supposed to be taught, and maybe you just were never taught in school. That's highly likely. How to use alternatives. And I got a good one for you because the shit works every damn time. But let's look at what I wrote, okay? Alternatives to restraints. Select all that apply. SATA, baby. Here we go. The patient may need a sitter. And they absolutely will need more rounding. Now, you probably say, well, shit, ain't nobody got enough staff to round every 2 hours, much less increase that to every hour or so. Well, we know that that's true, but you could have more people doing the rounding. Now, I know that in the EPIC system, you've got your PCNAs and they are supposed to be rounding on the opposite hour that you're rounding on, right? So if you're doing Q2 hour rounds on the even clock number, so 12, 2, 4, 6, 8, 10, they supposed to be rounding on 1, 3, 5, 7, 9, and this shit don't really get done unless you, my love, enforce the matter. So when I come in and I see somebody watching Netflix on their cell phone at the desk, and I'm looking at them do this, you know, for however long they do this, and they do it long time sometime. You know I'm going there, right? But you got to be politically correct, baby. You can't knock them upside their head because they sitting there watching Netflix for hours. I mean, really, for real. You have to say something. Oh, girl, I need you to do me a favor. Baby, when you get a minute, room 3 is driving me to drink. I really need you and me to double team him because we ain't finna go down like this with a fall and some old bull crap. No, me and you, girl, we got this. You know, make it a team. Like you ain't just dumping on the aide, because I've been an aide. I was an aide first, of course, right? Hello. I was an aide and then I was a nurse tech. And I mean, you cannot treat people like shit and expect them to be on team A, right? You can't. No. So if you never talked to her before that day, you never said please and thank you before that interaction, look for her to roll her eyes at you and keep it moving. The relationships you build with your staff, your ancillary staff. And I say ancillary staff, I mean dietary, I mean environmental services, I mean parking, I mean anybody who is not the nurse or the doctor. Anybody is going to set you up for success or failure. And the most important relationship you can build is with your aides. I make sure when I treat the unit to dinner, I find my aides to go in there first. I make sure that when I get anything done from them, I say, thank you, you are the shit, I love you, boo. Sometimes I'll go get an extra little hookup from the gift shop and give it to them, like chips or whatever. I mean, I ain't playing, I'm trying to have a good day, okay? So this sitter or maybe increase your rounding really does work. Some institutions and facilities have implemented a virtual companion. That means like a television screen, sort of like we do telemonitoring with the monitor, the EKG monitor leads are on the patient and they're on the telemetry monitor, the cardiac monitor, but somebody way off site is looking at the monitor to let you know when something ain't right. That's exactly how a virtual companion works. There is a monitor watching the patient. You can talk to the patient through the monitor. Mr. So-and-so, you need to get back in bed, sweetheart. Do you need your nurse? That actually works. Next, and I really want you to do this with me, with my family. Call in the family. Call that sister. Call that wife. This happened with my papa, and what we did when we got that call that he was beating a nurse's ass with his cane, we arranged 24/7 sitter services with fam because we love ours. I don't know what you're doing with yours, but our papa was in rehab. I don't really believe in nursing homes, but my papa was in rehab, and so, you know, this is a foreign place. They're trying to take his clothes off and all this other stuff. No. My family, that's what it's called. It's called a family. So my 2 daughters, my papa's wife, mama, right? So me, other kids, not just me, my brother, my sister, whatever. We arrange care for Papa 24/7. I got them kids that want to stay up all night playing games and shit. Go watch your Papa. Take your cell phone and your Netflix and go watch Papa. He was fine after that. Calling the family. Keep them closer to the nurse's station. Oh yeah, I'm gonna tell you about yourself. I had my little baby. I got to work. She was all tied up. I had never really met her. Her son was, we'll just say, a hot mess. But I called her son, and I wanted to know, because I kept tying this lady up, I wanted to know before she came here to our facility, what does she usually do? What did she used to do day to day, every day? Because it was tying her up. Every day it was tying this woman up. I just can't do it. So he said, well, she would be in a wheelchair and she would just kind of just go around the units and do her thing. I said, oh, for real? All right. I went and got that wheelchair for that lady. We put that lady in that wheelchair. I would wheel her around, so with the aides. Then we got to the point where she was family. She was always at that nurse's station. And when she was at that nurse's station, she was helping us. She was filing papers. She was folding towels. She was helping us figure out what should the patients eat that day. I mean, whatever it was, my girl was at the nurse's station. Got to the point where she was family. Because she was there a long time, waiting on placement. You know, some of these patients, depending on what they're doing and what's going on with them, they could be at your hospital a long time. And it was hard to find placement for her. Girl, please, she was family, close to the nurse's station. Bed alarms, chair alarms, side rows up ×3. Notice what I said. I said 3. And wedges will also keep the patient safer, because sometimes this is an issue of safety and you just want the patient to be a little bit more safer. You don't want them to fall. Wedges, side rows up ×3, the bed alarms and chair alarms are good alternatives. Remember I said that. Diversion. Now, depending on how big, how small, what shift, nights or days, the patient is doing all this here stuff, you could really have some really cool diversions. What are some diversions? What do we do to distract this patient? Diversions, right? Here we go. You know it's called a busy blanket. It's got snaps and zippers and buttons and Velcro and all kind of shit on this blanket, and you give it to the patient and they play with that for a minute. It's not as effective as I would have thought. I got some other things that work better. Dolls. As long as it's not, you know, an infectious disease issue with stuffed animal type of dolls, but real dolls wrapped in a blanket with clothes to change, that shit always work. And my kids had dolls coming out of their ears. So sometimes we got to take Molly to the hospital and let the doll get cared for, because my kids ain't shit. They ain't care for their dolls, and God knows when. One is 40, one is 30. Y'all pray for them. How about the facility dog? Oh my God, yes, my papa lived for the visit from the dog. If that dog comes around and visits that patient, you just made their day. You may not believe this next one, but it would help me. So let me just tell y'all right off the grip, when I get old and y'all my nurse, you know I'm crazy. I'm crazy as hell. I'll probably be one of the ones you had to restrain after a while. But just give me some music. If you give me some music, music is a wonderful diversion. Now, I don't want to hear no country music. That's for somebody else. You can't play what you want. You got to play what the patient probably wants. And the only way you're going to figure this out is either ask the patient or their family. If you put country on, I'm probably going to stab myself in the neck. If you throw some jazz on, for sure I'm slitting my throat. I don't like jazz. I'm not a country girl. But if you go and find that rap, Cardi B and YG and all of them, Chance the Rapper, and Kendrick Lamar, yeah, we good. But maybe they don't have that in your hospital because they don't have it in mine. So what's the next best thing? Motown. Those stupid channel that's on the little TV. You get that TV, find you some Motown, honey. Even 70s and 80s. These people, 70s and 80s music, 90s even, some of them. Think about what they might want to listen to. As God is my witness, when I put music on, my patient sleeps better. When I put music on, my patient's mood is better. I'm going to keep it real. When I put that music on, the nurses and the aides is better. And sometimes we just get to line dancing and and the patient joins in. Then we really have fun. Then we have some karaoke. Come on, y'all, sing it with me. You got to have fun at work. I'm not the boring type. I have to have a good time at the workplace or I gotta leave. Okay, so music, even art. Coloring books are a favorite. I know it sounds crazy, but I still like to color. And they like to color. These patients enjoy coloring. Okay, so there you go. Okay, now that was good, but this is the best. Can I just keep it real? I have never met a patient yet that didn't like this. So what is it? This is me. You are you. I'm pretending that you are my patient. Hey, Miss Martin, how you doing, girl? I need to get out of here. I need to get out of here. I said, girl, I know that's right. But let me ask you something. I'm working today all the way till 7 o'clock at night. And I was wondering if you could maybe help me with something. I got so much to do, girl. It's driving me crazy, like I'm going crazy. Can you help me with something? What is it? Well, I know you're very busy, and I'm just asking because I need your help. But I really was wondering if you could help me with some of this laundry. It's overflowing. I mean, the patients, they're using a lot of laundry. Is it okay if I just give you a few towels and washcloths to help fold and help me out? Because otherwise I'll be here all night and day and I'll have to do overtime and it'll just be ugly. And I need your help. I ain't met no one yet that said no. Here's what I found out. Your patients need a purpose. They need to feel needed, especially the ones that have been there too long. They need to feel like they're a part of this family because they've been here for a month already waiting on placement. I mean, whatever. These people want to have a purpose. We all do, by the way. So that folding towels, I swear to God, that shit works. But you got to fold it the right way now, honey. You got to take the washcloths and fold them like a little square. So when you get done, it's just like a little square. You fold it in half and then you fold it again. Now, I had a military man help me fold the towels and he was real precise, girl. He was like, put these corners together. And he was like, let me fold it. And get this, he would take it apart if he didn't like it and do it all over. It's all right with me. Your ass ain't getting into no trouble. You ain't falling. You ain't doing shit you ain't got no business. You ain't fighting. You ain't arguing and cussing and going on like you was yesterday. You got purpose, okay? So folding towels. Another favorite of mine, just because I know I would like it, is taking a walk. It don't have to be no long walk. It could be around the unit once, and you will get some cooperation when you're done. It's like a more friendlier thing to do, and they see you as their cool buddy who they're walking with, and then you're talking about things and discussing things, and they feel more like who they are, an honorable, respectful person. All right, so you good? Now, here's some other tips. Having familiar photos around worked for our family. In other words, when Papa was in rehab trying to beat the nurse up with the cane, we put Mama's picture up there. We put his only grandbaby, my daughter's pictures up there, even when she was a baby and when she grown. We did all of that, and that did help because it makes the place more like home. We also made sure that, this sounds stupid, but it's in every single test question, it's common sense, but let's make sure we say it. Put the call bell in reach. Tell them to call you if they can work with that, right? Keep all the items that they need in reach, okay? All right. let's do some more alternatives to using restraints on this poor patient. Camouflage their lines. Now, all of us know what we're doing with lines and camouflage, right? We put a sock over it, tape it around a little bit. We do all kinds of things to cover up the lines. LDAs means lines, drains, airway. Here's one that you might not think of, but it actually works really well. Maybe your patient is actually in pain, so the agitation is getting worse. They're squirming and trying to do too much, right? They're just doing too much. They're trying to leave, whatever. Assess and treat for pain. Here's another one. What's their pulse ox? Hypoxia will make you restless, agitated. You knew that. How about their electrolytes? What might be going on with the electrolytes, right? So think of those things. Toileting every 2 hours, right? If your patient needs to go to the bathroom, they're probably going to not want to follow all your little funky rules, okay? They're gonna try to find a way to go to the bathroom, and some of those ways can injure them, hurt them. Maybe they have an IV pole and they really shouldn't get out of bed with this IV pole and you know, whatever, and calm explanations. This may need repeating with the elderly, right? What do we know about older people? They need repeating. So when it comes to calm explanations, the best example I can give you is, oh, John, we really need that IV to stay in your arm. I don't want to have to poke you again, and you surely don't want to get poked again. So can you help me figure out a way to keep that in your arm and you not to pull it? Because I got a couple medications that the doctor wants you to take, and I need that IV. That actually works. Reorientation. Reorienting your patient. Well, remember, I'm your nurse and this is the hospital, and I want you to feel like you can call me for things you need. This is your age. Sarah's going to be with you. We're both going to be with you for this evening. And you see the time, right? It's 4 o'clock in the evening. So you are going to be in the hospital tonight. But I know your wife, Sally's going to come and make sure that you're doing okay and bring you some goodies too. She told me that. Offer nutrition and fluids. You know that lady that we used to keep at the nurse's station that I told you about that used to be tied up every time I came to work? It was like, why are they tying her up? And then one day I got her as my patient. I'd heard all kinds of horror stories about her, and for the most part, some of them were true. Ooh. So, but I just don't believe in tying people up. So this day, I come to work. They said, the towels ain't working, Shelly. I said, oh, for real? Okay, y'all. And she too loud at the nurse's station. She going off on everybody. I said, all right. So what did I do with my girl? I talked to her for a little bit, you know, while I'm passing meds. I kind of chit-chatted with her, going back in the room, back and forth. I said, let me ask you something. Can you help me go grocery shopping for certain things that I need? Can you help me with that? Would it be okay that, you know, you go with me and try to find out what people want to eat, and then we can also shop for you too? I got to get you to help me with the store list. That worked. How did we go shop? Because you can't really lie to people. Where did we shop? Well, I shopped right in our kitchen, and I had her write down and tell me what she wanted. And I brought down all this stuff from the store. So I took this big box top, and I don't know where I got it, whatever they delivered that day. It's a box top. It might even have been a tray. Who knows? And I arranged all the food that we do have, which sometimes ain't much, but I tried. I arranged it so that she could pick and choose what she wanted. So there is ice cream and there was sherbet. There was, because everybody usually has that. There was graham crackers and there were saltines. There was peanut butter, there was jelly. On this side, there was vanilla pudding and there was chocolate. There was applesauce and there was yogurt. There was peanut butter and jelly sandwiches, and then there was ham, and then there was turkey. And I mean, I just arranged it so that she could pick out what she thought would be good. Hey, I was desperate. I had nothing to worry about with that lady the whole day. I know, right? Who knew? Now, she went back to folding them damn towels later that evening because it was, you know, I needed help. It depends on how you present it, for crying out loud. All right, so fluids, she had her pick. Orange, grape, apple, whatever. Ginger ale, whatever. Gatorade, whatever your facility got, you got to make it look like a store, honey. Now, let's talk about why restraints. Let's really talk about it, because I think that it's very valuable for nurses to know the signs of impending violence. Even just me, I'm like, the other day I was getting a report from a brother, and that baby was saying to me that this patient had a problem with code violet a few days ago, but they've been fine. And I'm looking at the patient while we give a report. I'm one of those nurses who always gives report in the room. I'm looking at the patient and she's mad. She's mad right now at 7 a.m. She's mad. And she's talking about how she got to get the fuck up out of here. And this is some bullshit. She don't know what's going on, but she can't be here all day. And they really ain't really taking care of her. And she has an IV. She's an IV pole. And she's kind of walking a little bit. I would even say that she's pacing. She definitely fits the agitation model. And guess what? Brother man said, oh no, she's fine. She's not going to be a problem for you. I'm like, oh no, because she already agitated and she's pacing. And I just kept my eyes on her while he kept giving me report. And then she started getting what? Louder. She starts getting louder. I want to know, when can I go up out of here? I mean, just getting louder. Y'all bitches better get me the fuck up out of here. I said, oh, hell no. I'm going to go ahead on and call a code violet because she done lost her mind. So what did I have? I didn't have a whole lot going on. Look at what I had. I had a little bit of pacing. I had the agitation. I had the voice getting louder, even screaming. And then we were bitches. So, hey, name calling. That works. Now, what else happened before Code Violet came? She threw her fucking tray table, y'all. I say, see, this motherfucker here. Oh my God. So now listen, you have a legal responsibility to assure safety of all the people in the room. She had a roommate. I had to get that roommate up out of there yesterday because she was on a whole nother level. Now, it turns out I did not end up restraining her. We actually got along really well throughout the day. We never restrained her. The cops did come, Code Violet. They came on in there and talked to her about, yeah, it's kind of inappropriate for you to be throwing shit up in this bitch. You know, that kind of discussion. But you need to recognize the signs of impending violence so you can protect yourself and your patient. Screaming, name calling, throwing, and slamming stuff. Slamming doors, slamming books, slamming whatever. Clenched fists, oh yes. Gritty, gnarled teeth, clenched teeth, They violating your space. Y'all up in your face with this shit. Oh, hell no. I'm going to need you to back the fuck up. So violation of your personal space. Like, they just get closer and closer. And I'm like, oh, for real, girl? That's what you want? Okay. Alcohol and drugs. Come on, let's keep it real. 1 in 6 hospital admissions are alcoholics. And a good 50% of them will beat your ass. If your patient is on drugs or alcohol, I'm really famous for assessing whether or not that's the situation and just keeping it cool with them because I like to be cool with my patients and making sure that I talk to them because this is not a restraint if they agree. that I talk to them and explain that, you know, while you're here and not really able to get your drink on, you might feel more and more anxious, like high anxiety, like for real, like mad even. I said, if you feel that kind of like coming on and you feel like, I'm getting irritated at every little thing, let me know. The doctor has covered you with a medication called Ativan, and it will ease that anxiety. It will ease your nerves, and you know, it'll help you out until you want to stop drinking for good. Okay, so let me know. I'm your girl. Like, just keep it real with me, okay? And that works. So alcohol and drugs. What am I doing? Huffing and puffing. Your patient huffing and puffing? Yeah, cold violet need to be called. Why is you huffing and puffing? You ain't COPD. You ain't even got a respiratory problem. Nah, you huffing and puffing because you ready to fight. Like, let's do this, you know, breathing all hard, looking all crazy. Okay. They had a history. You find out they beat the shit out their wife yesterday. Oh, you thought you was special? They gonna fuck you up. So any history of domestic violence, cold violets on the unit, they was called last week on them twice. Use your sense. Like, come on now. If they threaten you, guess what? They might do it. Threats are a reason to call a cold violet. Absolutely. Now, you might be thinking we just talking about patients. Shit. Let me tell you something, honey. At my facility, we have Starbucks all over the place. The Starbucks lady called one of my colleagues a stupid bitch. That's sweet. So, you know what I made that colleague of mine do? And she used to be a former student too. I made her write a SIRS report because we're not about to have this. The lady who calls the customer a stupid bitch or silly bitch or fucked up bitch or bitch any way you bring it is probably going to be someone that could shoot up a facility as well. So just think what you doing. All right. Now, we want to remind you why you needed the restraints and why you don't use restraints, right? We use restraints in terms of your documentation if the patient is at risk for interruption of medical therapy, if the patient is pulling at lines, drains, and telemetry leads or monitors, if there's an issue of violence or suicidal ideation, and it's not appropriate to use restraints for patients getting out of bed, they're wandering, you think they need to be punished, or you're short staffed and you're like, fuck, tie them all up. Restraints must be discontinued at the earliest time possible that would be safe for patients and themselves and the staff. And always, here's a good one, always notify the family that you put this patient in restraints. The last thing you want is for someone like me, a very devoted, dedicated family member, to come in and see their mama is tied up and you ain't know shit about it. So this is an issue. It's usually something you have to document as well, to notify the family that you needed to use restraints. Because sometimes the family say, okay, yeah, you know what though? That's cool, I get it. But I'm on my way in, so maybe, you know, when I get there, we could look at maybe not using them. That sounds good to me. Now, I hope you learned something. The next video will be all about ethics. Have a good day.